Gentlemen, dear colleagues, I'd like to thank the Scientific Commission of the Society for inviting me to present this and to defend the notion that we need less transfusion of red blood cells. It's very frequent in our units, and what testifies to this is the ABC data published in 2002, which at the time showed that intensive care patients often underwent transfusion, and those who stayed more than a week, more than half of them required extra compact blood cells. And similar cases were reported in our American colleagues through the CRIT study, with similar figures. Over half of the patients who spent more than 7 days in intensive care needed transfusion, and the parents who spent more than 2 weeks in transfusion, 80% of them need a red blood cell transfusion. We're all convinced of this on a day-to-day basis. We see that we're going to be talking about a problem which is a problem that is often encountered. So this problem is a recurrent one. Over the past 20 years or so, we have much work, the body of work that tends to suggest that red blood cell transfusion can be harmful. There are observational studies such as this one, the study of our moderator, which gathered data at the end of the 90s and that reported that patients who underwent transfusion in IC had a worse prognosis than others, including the propensity score, and similar data again were reported by the American study, the closely related study, with a similar methodology with patients based on data collated at the beginning of the 2000 decade. Transfused patients have a mortality probability which is higher than for non-transfused patients, including on the prognosis, the usual prognosis factors in IC. This dichotomy between transfusion and non-transfusion patients is perhaps not the most relevant for us on a day-to-day basis. On a day-to-day basis, what we're looking at is a red blood cell count and the cost, the risk-reward ratio of compact blood cells. You know the study, which is the PIVOT study, and the study on which all of our analysis and further studies were based. This is the Paul and Berg study that was published in 1999 with patients included in the study in the middle of the 90s, which randomized patients to be given packed red blood cells in intensivist care with the classic transfusion data, 10 to 12 grams, versus a restrictive strategy of 7 grams of hemoglobin per deciliter. You're all aware of this study, and the idea was that there was no significant difference in terms of mortality between those patients. The restrictive strategy enabled, preserved a large number of packed red blood cells, but if we look at the survival rate, the impression was, or the tendency seemed to be, that there was a better survival rate amongst patients who underwent less transfusion, and this became significant amongst the less severely hit patients, the younger ones, and patients who had a critical score that was less high. Regarding patients for whom there was some concern as to maintaining high red blood cell levels, who displayed cardiovascular comorbidity in the broad sense, not just coronaropathies, there was no significant difference, but the reverse trend in terms of mortality in relation to the results of the in extenso study. So on the basis of this work, 10 years ago, there was a consensus conference that was organized by the society that recommended a transfusion threshold for majority of thresholds in order to maintain a threshold of 7 grams per deciliter, and then depending on the level of cardiovascular comorbidity, transfusion thresholds which were between 8 and 10 grams, a bit higher in this population, in the high-risk population, in the event of ischemic syndromes. That was the result. Several criticisms were leveled at the study. In particular, it was published in 1999 with patients who were included towards the middle of the 90s in Canada at the time, with a use of packed red blood cells without leukocytes, and part of the harmful potential impact of red blood cell transfusion was potentially attributed to the lack of leukocyte content. But ultimately, more recent studies, such as this one, which was published a little less than 2 years ago in the United States and in a UK journal, based on a fairly similar system, randomized patients, elderly patients with a fairly stringent threshold in excess of 55 years, who were ventilated mechanically. And in this study, which is on a lower scale, we had a similar trend with a decline in mortality among patients who were allocated to the restricted transfusion category. And we have another situation which is fairly closely related to intensive care, which also suggests that a restrictive strategy is not necessarily harmful, can actually be beneficial in the post-operative phase in the case of cardiac surgery, whereby a restrictive strategy was no worse than a liberal strategy in order to maintain hematocrit at a significant level to protect against any events during the operation. And in traumatic injury intensive care, this was quite complex. It was a randomized clinical trial. When we look at the randomization based on the thresholds of hemoglobin and on the neurological recovery, well, we find no difference. In this study, it was mainly concerning patients who were not severely hit. It was on patients who had suffered digestive hemorrhage, and the study concluded that there was a positive impact from restrictive impacts with 7 to 9 grams of hemoglobin per deciliter, as opposed to the higher dose. And this was accounted for in part by a lower occurrence among patients who were in the restrictive strategy category, and the patients suffering from cirrhosis who were in the liberal strategy tranche actually had their gradient with ischemic impact going higher than for those who were in the restrictive strategy segment. And another situation for which the recommendations of the SRLF had recommended higher hemoglobin levels, which is the simulation of coronary ischemia. And the level that was recommended 10 years ago was to maintain hemoglobin in excess of 10 grams per deciliter. In medical research, we have suggestions that the restrictive strategy for transfusion could be accompanied by lower mortality, a lower occurrence of ischemic events, and of course improvements can be made. These observation-based studies, in other words, transfusion versus no transfusion on different thresholds, but they are observation-based. And in this meta-analysis, there is one study that is randomized. However, the end result of meta-analysis argues in favor of a restrictive strategy, including for this category that has myocardic ischemic with the negative impact due to excess transfusion, increase in blood viscosity, and early thrombosis and stenosis in patients who have undergone angioplasty and stent interventions. What we see in intensive care very frequently are nosocomial infections. Now, there are various articles, research papers that show that the number of transfused packed red blood cells were independently linked to the emergence of nosocomial disease, and this impact was highlighted very recently in a meta-analysis that was published in the JAMA, which brought together some randomized trials and which established an overall impact between the transfusion of red blood cells and the development of hospital-acquired infectious diseases, not only in IC, but most of this work was implemented outside of the IC sector. Now, here's something that we don't take into account at present, but which may account for some of the negative impacts of transfusion. This is the age of the red blood cells, and certain things happen within the blood pouch before it's passed on to the patient. It may be biochemical changes that take place within the pouch that may have consequences for the patients, and one of the consequences that the packed red blood cells may not be, the transfusion may not be immediately operational, not in terms of transport, but in terms of bringing oxygen to the tissues. And when the packed red blood cells are taken, there is a rapid decline of 2 to 3 DPGs, and this has a left-oriented impact for the structure of the cells, which means that they will bring less oxygen to the body tissue, and this means that we need 12 to 24 hours for a hemocyte that's been transfused to recoup its normal DPG. And there are also phenomena within the pouch with a re-injection of bioactive substances that may account for some of the negative impacts that we have established, and in particular the impacts on immunomodulation. But this consideration of the age of the packed red blood cells was found in particular in cardiac surgery, where patients were randomized as receptors of packed red blood cells or old packed red blood cells with a cutoff age that was set at 2 weeks, and then there was an increase in serious complications after surgery among patients who'd been randomized for getting quote-unquote old blood. And in intensive care we also have observational studies such as this one, which suggests that when you are given older blood, you are at greater risk of mortality in intensive care. So I think there's a whole series of evidence that suggests that one needs to have a restrictive attitude towards transfusion, and the threshold that has been suggested seems reasonable for most patients. And then there's a situation which raised questions, and it continues to raise questions, which is sepsis, because in sepsis there was a 2001 study which in the algorithm at the time for hemodynamic care suggested a level of hematocrites in excess of 30% for patients for whom tissue oxygenation remained insufficient, and the objective level was defined by the level of CO2, which was less than 70%. And if you look at the results of the study and the different therapeutical attitudes that differentiated the two tranches, the main difference between the two groups. You see the early goal group, approximately 70% of the patients underwent transfusion in the first 72 hours, as opposed to those allocated to the standard segment. And at a time when patients really underwent high filling levels, and this may account for the discrepancy in the transfusion process that we saw, because there we saw that there were less than 20% of patients who've undergone transfusion of red blood cells in the first 72 years, very different from the 68% of the Princeps study of Rivers. But in that case, patients underwent a filling level that was 3 times less, or it was reduced in the first 72 hours. The question was kept going by the observation study, which that you see that suggested that in the population that has suffering from sepsis, after statistical adjustment by a propensity-related score, patients who'd undergone transfusion of red blood cells had a better prognosis than those who did not undergo this. And a similar result was achieved by our Korean colleagues with a similar methodology, and this is the result of the adjustment on the propensity score. And after adjustment, the patients who'd undergone transfusion displayed a lower mortality rate at 28 days or in hospital. Since then, we have had the TRISC study published at the end of 2014, which amongst the septic shock patients had randomized them according to the two categories. With the 7 gram and 10 gram per deciliter distinction over 10 days, with a lower resort to transfusion and complete lack of any effect. It was on a 90-day period, in fact, and it was an excellent study. But should we leave it at that? Because this linear aspect of the concentration of hemoglobin certainly does not reflect the variability of patients over time and over the past 28 days, because we're going to go through the initial period where you have tissue ischemia related to sepsis. The patients will recover, and then there will be other septic events with, once again, tissue ischemia, and perhaps a therapeutic attitude that would have been more physiological, more reasonable in relation to the patient's condition, would enable transfusion strategies that would vary depending on the situation, that might increase the transfusion threshold in the event of tissue ischemia, and conversely, in a stable period or between sepsis events, one could go back to the transfusion threshold that is in all the recommendations based on the Canadian studies. So do we have arguments in favor of recommending this approach? Well, there aren't very many, I must say, but there is the article that was published last year. I think it's a good article. It's very difficult to conduct this, and it answers a question that we often raise. But basically, this work looked at patients who, once they've been in IC based on the Rivers algorithm, who still have tissue ischemia, then we have to ask ourselves whether they should undergo red blood cell transfusions. And they looked at this small subgroup of patients who could benefit from further intervention, and which there were 71 patients who had undergone transfusions of red blood cells, and looking at a statistical adjustment with all the restrictions that entails, adubetamine had not significantly had any impact on survival. But after the propensity score, well, the transfusion of red blood cells afforded protection in terms of mortality without significantly modifying the central venous saturation. So that's just by way of a different strategy for patients in the sepsis phase. And here is a more physiological aspect, this is what work done by a Greek team. The evolution of tissue ischemia assessed by dialysis. The higher the ratio, the more it reflects tissue ischemia. They looked at sepsis patients, but in the late sepsis stage, 7 days after the beginning of the sepsis, so quite late in the process, patients who still had noradrenaline, but with low transfusion speeds, 0.4 milligrams per hour for somebody of an average weight. So in the late stage of sepsis, they looked at the impact of the transfusion with an overall impact observed 2 to 5 years after, which showed a decline in the lactate-pyruvate ratio with very significant variations between individuals, with impact from other therapy interventions. And this applies to all these studies that examine tissue ischemia in this particular context. So, to transfuse less, well, there are perhaps other things that we can do, limit the loss of blood. Hemoglobin solutions, the development of which was stopped due to ischemic events in the first patient surveys. And then erythropoietin enables the reduced use of transfusion, but it does not allow for a reduction in morbidity of patients in intensive care. And other studies show that erythropoietin treatment is more expensive than non-treatment using erythropoietin. So to conclude, I think that for most of our patients, we can emphasize a restrictive strategy with all the information in literature that enables us to do this, with a clinical impact in terms of mortality, and very effective in terms of dealing with nosocomial infections. The situations in which there is insufficient tissue oxygenation, and in particular in the acute sepsis phase, regarding the age of the packed red blood cells, we have a study that should give us information on the impact of the age of the packed red blood cells, looking at the difference between the 1-week-old cells, and the transfusion strategy that we should probably emphasize is an individual, personalized